Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stuckey. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. All right, welcome to another episode. Today I'm with Dr. Richard Marn. He is an MD anesthesiologist practicing in the New York City area. Richard, thank you so much for joining us on the podcast today.
Thanks for having me, Grant. Appreciate you wake up early to hang out with me.
Oh, for sure. Love it. So can you just give us maybe just a brief kind of history of your training and your current practice setup?
Yeah, so I am currently a pediatric anesthesiologist and also a board-certified anesthesiologist. So, and right now I specialize in mobile sedation services, especially for dental and oral surgeons. 82% of my practice is pediatrics, so I take care of a lot of kids, which is a natural thing for me as a pediatric anesthesiologist. But in terms of how I got here, I born and raised in Hawaii, went to college at Washington University in St. Louis, went back to my home state in Hawaii, got my medical degree, and then I spent a year in Denver, where you're from, doing my surgical internship. I thought I was going to be a urologist. That didn't, of course, that didn't play out. So I pivoted to anesthesiology. I went to NYU for that here in New York, and met my wife, who's actually a pediatric dentist here in New York City as well. And I went to Johns Hopkins for my pediatric anesthesiology fellowship. And then my first job I took after training was Mount Sinai. So I was there for 11 years doing like real pediatric medical cases. So, tonsils, adenoids, or hernias, but also like 2-year-old liver transplants, 1-year-old craniotomies, and 5-pound premature kids for thoracic surgery, like really high acuity cases. And it really allowed me, I hate to say, but kind of cut my teeth, if you will, in medicine after training. And then after that, 2016, I left Mount Sinai to go into mobile sedation services in dentistry and oral surgery. So that's what I've been doing for now 9 years.
Oh, very nice.
Years. Yeah.
Yeah, that's awesome. Sure, you got a lot of different topics that you could potentially teach us. We wanted to talk just a little bit about kind of sedation emergencies, how you prepare your staff for those things. Where would you start us off if you're speaking to a group of oral surgeons about anesthesia emergencies?
I usually start with saying that I think the main thing to really make sure that you are prepared for a sedation emergency or even a medical emergency is ultimately you want to make sure your team is stress tested for that event. All right, especially if it's a third party that does that. That's the ideal situation, because that's, if you look at every high performance team, they're always stress testing it. They're always stress testing their team, and they need feedback, right? So that's the ultimate way that any team prepares for any situation, whether it's a F1 Formula Racing, or it's a Navy SEALs, or it's the best teams at the top hospitals in terms of getting ready for those kind of events. So to do that, there's like 4 principles or 4 pillars that I found is what people need to kind of get there. And so, do you mind if I go through those 4 pillars, Grant?
Please, that'd be great. Yeah.
All right. So the first pillar is infrastructure. All right. Number 2 is competency. Number 3 is culture, and number 4 is habit. And if you don't mind, I'll break it down here. So infrastructure is the equipment and the infrastructure and the design, right? Your physical space that you have for a medical emergency. For example, do you have enough lighting? Do you have the right equipment? Do you have MESV, which is just a term I kind of came up with. It's MESV. So you have your medications, equipment, supplies, and visual aids. So visual aids is like, you know how you go to CPR and you get that little card or you have a checklist? That's a visual aid or cognitive aid. That's what we use or say in simulation training. All right, so MESV. So that's your infrastructure. And also, do you have appropriate ingress and egress into your facility? So another example of that is there was a sedation emergency for an oral surgeon here in Manhattan a few years ago. I heard this through a second party. I want to be transparent there. But the person that was there described how when they called for this emergency on this 70-year-old patient who basically stopped breathing and they called 911, the paramedics went to the wrong door because they couldn't find the facility. And mind you, this is Manhattan, right? So they went to the right floor, but they couldn't find the right door because it wasn't marked. So that's an infrastructure problem. Okay.
Yeah.
So that eventually the patient, the paramedics came to the right door. The patient got escorted to the hospital, and I heard the patient did recover. But again, that delayed care for that treatment for that patient. The second aspect is competency. So that means each team member team member well trained for a medical or sedation emergency? And what does that mean? That means do they have the individual skills as well as the teamwork skills? So individual skills are like CPR, knowing how to draw up medications, knowing where to find the equipment and use equipment. But teamwork skills is, do you know how to work together as a team, right? And that's a different thing. Like, if I say, hey, Grant, go do CPR, you'll know it. But how do you work as a team? And do you know how to communicate? Do you know how to identify problems together? That's a different skill set. And sometimes that's a lot of soft skills as people kind of identify. So that's competency. The third aspect, which is probably less talked about and less identified, but is very important as we find in training when we're training these anesthesiology residents at Harvard hospitals, is culture. And what is that? Culture means how well aligned is your team with your own practices, values, and priorities and objectives. And so it sounds kind of fluffy, but it really says, are you on the same page? Have you created a space where you can communicate and share problems and speak up? Right. So there's the concept of psychological safety. There's a concept of being on the same page or shared mental model. Right. Those are very important for creating a safe culture. So, for example, you're taking care of a patient doing sedation, right? And the pulse oximeter now starts to read like maybe low 90s or even 80s. And you're kind of, as a surgeon, you're kind of so focused on this thing, and maybe you're kind of not looking at the pulse oximeter. But your team, your assistants, may not speak up. They may not say anything because maybe you haven't created this culture where you feel like you want them to speak up and you want them to help keep the patient safe, and you create this safe environment, right?
Yeah.
And so what happens is not patients, but your assistants won't speak up because they don't feel safe to, or they assume that you don't want them to speak up. So having that ability, that culture that creates that environment for people to assist the oral surgeon in a sedation emergency is vital, and it's not talked about. I've worked with a number of oral surgeons. I have about I've worked with the last 2 years. I've worked with about 25 oral surgeons. Okay.
Okay.
And there are certain people that don't create a very safe environment for people to communicate what's going on, and they expect the oral surgeon to tell them exactly what to do. And so now all the burden is on that oral surgeon. So that's a cultural aspect, and of course that comes from leadership and creating a environment where sedation emergencies is on people's mind. Which leads me to number 4, which is habits, which is about asking how embedded are sedation emergency readiness plans in your day-to-day habits. Okay, so do you actually make it a habit, a is there a cadence to your day where people are thinking about medical emergencies, sedation emergencies? For example, do people check your equipment on a regular basis? Do you talk about it openly? Do you sometimes have somebody designated um, for those emergencies that can help assist in terms of communication? So that is the habit. And then, of course, I'll give you an example. So we make CPR a habit. All right. I think it should be done more frequently in terms of training, but habit uh, is a little bit more deeper than that, because sometimes in the simulation training research, they found degradation skills drop off notably after about anywhere between 1 to 6 months, and it almost goes back to pre-training. And so you need to have that habit, that practice, to make it top of mind. And it's also making sure that maybe some offices, what they do is they designate a sedation a medical emergency liaison to make sure everybody's up to date with the latest training and making sure all their competency is up to date too. So that's part of habit.
Love that. That's a good way, I guess, to get the main structure here of those four pillars.
Well, a lot of people tend to focus, I notice the dentists especially and oral surgeons, they focus on the first two, which is natural. I got all the equipment, I got the supplies, I did my CPR training, and we do some webinars. And so there's a lot of emphasis on the first two pillars. I mean, the typical dentist and oral surgeon I talk to, when I ask them, "Are you ready for emergency?" They often say, "Oh yeah, we do CPR. We got our defibrillator." Okay, that's great. That's the first two, but you actually have to go a little bit deeper, kind of assess that, if you will. All four of those pillars.
Yes. I mean, I like culture and habit. In our setting, a lot of private practice oral surgeons who are doing the routine teeth and titanium is what we call it. I mean, 99% of the time, everything goes smoothly, and we could go years without having to intubate a patient, without having to call EMS for anything. And so sometimes I think can potentially get into like a complacent area where it's been a while and maybe you're not realizing some of your new team members, or there's been turnover and people
Yeah,
just haven't been really trained to, like you're saying, be stress test and know how to function in a stressful situation.
yeah. You're right, Grant. I mean, look, I'm not going to sugarcoat it. Sedation emergencies are what we call halo events. You know what HALO stands for, by
Tell
chance?
me no.
Oh, okay. So HALO stands for high acuity low occurrence.
Okay.
High acuity low occurrence, right? And
Yeah.
quite frankly, that happens in medicine too. I mean, how often does an ER doctor let me phrase it this way. How often does a paramedic typically do a tracheostomy? It's rare. It's uncommon. All right.
Yeah.
How often does a ER doctor do a big line placement in an emergency situation? Um, or I'm sorry, they have this tool that helps stop emergent esophageal bleeding, and I'm forgetting the name of it. And it's done very uncommonly. And they actually did a study on this, and they did some training to see how quickly people can place it after just one training. The fact is, it's a halo event, and most people don't see some of these events. And so the problem is this: it's uncommon, but the problem that I see with halo events is from what I can tell, it's the only event or the biggest event where if it occurs to your practice and you don't respond well to it, it is the most devastating thing that can ever happen to your practice. So take a worst case scenario. Someone dies, maybe a kid dies, right? Maybe a 14, 15, 18-year-old teenager doing wisdom teeth, and it goes wrong. And now you're going to get bad publicity. You're going to get potentially oversight by a regulatory organization in your state. You're going to get your name, you're going to get very bad Google reviews. You're going to get bad team morale where your staff now maybe starts I don't want to be part of this, and you start leaving, and you can't retain employees or staff, you start to, and then that affects your hit, your financially. Your patients now are like, what? Oh, this is a bad rep this guy has. I don't want to go there. And potentially your practice shutters. And I only say this because if you really look at these cases, this actually has happened to oral surgeons, right?
Mhm.
There's oral surgeon in Wisconsin that this happened to. Um, Another in California. I mean, this happens across the board, across the country. It doesn't happen often, but it's the single event that will like really shut your practice down more than anything else.
And I think we take that for granted that those events can potentially have those results because it's rare. We don't see that happening to many people, and it seems like, the day to day is pretty smooth, and we kind of ride the wave of all the stuff we learned in residency and, think we're competent. But I mean, what are some of the things you do to you kind of mentioned some of them, but like some of the habits type stuff, how do you keep your team in that habit?
Yeah, great question. So for what I do to get my team ready and encourage oral surgeons I work with to do so, what I do is every quarter, and lately I've been doing it more frequently, but every quarter I do a little mock drill, a little simulation. Sometimes a tabletop exercise, sometimes I'll get their hands dirty, if you will. And what I'll do is before we start the day, say we have one case and we say we have four cases, whatever the case may be, I will literally do a little walkthrough, a little what if situation. I just did it the other day, for example, with an oral surgery team here in Manhattan. And what we did is I prepped them. I said, listen, we're going to take 5-7 minutes. I just want to walk through a little tabletop exercise. We're going to stand around the table. We're going to act as if I'm a facilitator, not an anesthesiologist, and I'm going to just walk you through it, and I want to improve your communication. And I want you to behave as if you're doing a sedation emergency without me being here. So, as you know, a lot of oral surgeons do sedations without an anesthesiologist. So here's the situation. It was a 19-year-old boy, and they started having these symptoms. And then what do you do? What's your next step? And I kind of pause, I wait, and I use the same training and tools that we do for, these Harvard hospital residents. So as a side note, I am part of Center for Medical Simulation. It's an organization that's a nonprofit that is based in Boston, and they get hired by certain Harvard hospitals like Mass General and Boston Children's to train their anesthesiology residents and attendings for medical emergencies. And it's actually required by CRICO, which is their malpractice insurance, that they get this training. So I'm part of that group. And so we use some of that same training and tools to get them ready. And so we basically do a little pre-brief, a simulation, and a debrief. I make it very tight, makes 5-7 minutes, and it just gets people on the same page, and we make it a habit. I get them top of mind, kind of creating that culture, create it safe. I get them some feedback. It's fascinating to hear what they say. And then we do the case. So I make that a cadence. I make that a habit. So when the staff has me come in on a regular basis, they know at a certain point, Richard's going to do a little preparation for us. And it's also other things too, Grant. It's like little things like, do you know how to turn the portable O2 tank on?
Yeah.
Like the E-tank. Silly thing like that, right? There's a few knobs there, and it's not so intuitive which one you open or close first. And practicing that, a simple thing like that, can actually really help the team, because sometimes when you're in your busy practice, Grant, you're like, okay, why do I have to do this? Let's just get on. I got to get this implant going, and we got to start the sedation first. And I got this other patient I'm backed up. I'm not gonna talk about E-tanks. Come on, that's ridiculous. But that little simple thing, like say if you're a sedation emergency and you're trying to manage the airway, you want someone to turn the oxygen tank. Well, you need that O2 tank to work. And so simple thing like knowing how to put the regulator on. And by the way, what if that O2 tank, where it runs out? Does your staff know how to change the regulator to the other tank? And I would tell you about 50% of the time, people do not know how to put that E-tank on, that regulator. So simple things like that. Those are like, again, that speaks to the second pillar, which is competency.
Yeah. And I feel like there's, like you're mentioning, there's so many small aspects that have to go into your ability to successfully handle an emergency. A lot of little technical pieces, like you're saying, well, okay, where's the bamboo bag, and are the attachments there, and is the little bag that's part of the mask, is that inflated, and do we have a syringe to inflate it? Like it goes on and on. And so checking all of these things, do you have your ET tubes and lubrication and the stylet and like all this stuff? Sometimes I think for most oral surgeons can be on a back burner, and it's critical to be reviewing this with things and having someone check all your stuff, if not you yourself checking everything on a regular basis.
Yeah, you're right. I mean, like, listen, I can tell you, you know what to do, right, Grant? You know how to manage that airway. You know what the equipment is. But quite frankly, when shiitake hits the fan, right?
Yep.
What is everybody else doing? Like, do they know how to help you? So everything now. So this is what I've observed. When there's an emergency, a lot of the dentists, oral surgeons feel like it's a big burden on them. Like I have to do everything, right? The heart rate's down to 30, the SATs are 50 something, the blood pressure is cycling, but it's not like holy crap, something's happening. I'm going to do all this stuff, and everybody's just standing around looking at you what to do, and the fact is they can help you, but
Mm-hmm.
because you haven't practiced with them and you haven't talked about it, even for 5 minutes, 5 minutes every 2 weeks, or even 5 minutes every week, right? Just starts to get them on the same page as you so that when that happens, it becomes more second nature. Because I would tell you, look, I've been into a lot of sedation emergencies. This is what anesthesiologists do, Grant. Little digression. What an anesthesiologist does, and this is what I heard, and someone said this, and I totally agree. What an anesthesiologist does is kind of put someone close to death, but brings them back. All right. That's what anesthesiologist does. It messes around with your reflexes and your blood pressure and your heart rate and even your SAT sometimes. But the key aspect of anesthesiologists is they know how to bring someone back. Like me, we can teach people how to inject meds all day long, even a high school student. All right. That's not a problem. The unique point of anesthesiology and a good anesthesiologist or a great one is they know how to bring that person back safely, right? And by the way, discharge them that same day. That's someone with minimal side effects. That's a great anesthesiologist. So it's not about what drugs I can give. It's about how to recover when things are not going quite according to plan. And so that again speaks to these emergencies because sedation is a high risk activity. You know it. I mean, it's
Yeah,
more high risk than just you using local for sure. But the fact is, you're right. The team it's like I said at the beginning, it's all about team alignment. Can your team support you? Because otherwise, when that happens, Grant, it's all on your team. I'm sorry, it's all on you. That whole burden is
yeah,
on you. And you don't want to be teaching the team when the patient's decompensating. That's a terrible time to prepare for things.
for sure. Now, is there things that you do? Um, let's say you're doing 5 minutes a week or 10 minutes a week or something with your team. What do you do to like keep that going and make it so it's not just the same spiel every time?
Mm.
How do you keep it exciting and interesting for your team?
So that's there's a lot to do. You'd be surprised. You think 5 minutes and even let's say once a week, 52 times a year, right? You talk about medical emergencies. You do a little huddle, right? So it can be anything from turning on knowing how to put the regulator on the O2 tank, learning how to connect the ambu bag to the right port on the O2 regulator. Remember, you're dealing with oral surgery assistants. They may not know where to connect the ambu bag, right? It could be, and by the way, why do we even need an e-tank? Like simple questions like that.
Yeah,
Like why do we need an e-tank? Because a third of your medical emergencies are going to happen outside of the chair, right? A third of your emergencies. So you need something portable. Number two, the O2 from the wall typically is not going to give you the high pressure you need to break laryngospasm or bronchospasm. So you need the E-tank. And so talking about these little simple things with your staff, again, gets them to understand why you need certain things, why it's important. Okay. So so you can go through those 4 pillars, right? So you basically break it down, medications, equipment, supplies, visual aids, right? MESV. So for example, if I was at your office, I say, Richard, we want to do a program every week, want something nice and tight, very small. Okay, we'll break it down by those 4 pillars and we'll change it up every single week. So it's not just one pillar for like 4 months. Okay, so for example, we'll talk about medications. Do you know where the medications are, team? All right. What if there's only one person that knows that where it is besides you, and that person's on vacation and an emergency happens? So does everybody know where it is? Does everybody know how to drop the epi? So we do simulations for dental offices, and we did a simulation for not too long ago for 2 of these offices. It is not uncommon for offices to open up their emergency kits for the first time in our training, and they've had this kit for a year.
Wow.
All right. Yeah, it's the idea like, oh, I bought it, so I'm ready. No, you got to open it up. I literally the EpiPen was still in its packaging. The albuterol inhaler was still in its packaging. It was never opened. What if you think it's hypoglycemia? Do people know how to use a glucometer? That's not so intuitive, right? Do they know how to do a pinprick on the finger to draw blood?
Yeah.
Right? Because you can't, again, Grant, say you're managing airway, or maybe you're trying to place an IV in and the patient's decompensating. Well, you don't have time to be getting up the albuterol or getting the epi out ready. You need them to do that. So going through just your kit, what if your emergency happens in the hallway? I'll give you an example. We did training for an oral surgery practice 2 years ago. 6 months after that training, a patient stood up after a procedure, got vasovagal, fell down, hit their head on the ground, and split their scalp open, and it was blood everywhere. All right, it was a big deal. But because we did that training, the staff at the front knew to call the emergency services because they had practiced that. And it wasn't just any emergency service. It's actually a Jewish community oral surgery group. And so they had to call Hetzlah, which is this Jewish organization that's faster actually than 911. And that group of gentlemen, these paramedics, were there in like 3 minutes.
Wow.
But because we did the training, they were able to call them. But before the training, it was revealed that that they didn't know to call that number. And the oral surgeon said, oh my goodness, you got to call these people instead. Don't call 911. Yes, you can call 911, but call these Hetzlah first, because they will respond much more quickly, and they are familiar with who I am in my office. And so because we had that training, that team at the front desk knew to call the right people, and therefore did not delay care. In fact, they expedited it. But the point is that they, I kind of lost my train of thought there. But the idea is going through these aspects of your equipment to make sure everybody knows how to use what you need, all right, or what you have in your office, all right? So that's like the habit, like competency, simple things like this. Here's another thing you could do with your office. Hey, everybody, do you remember, we did CPR training like 6 months ago or even a year ago. Hey, do you guys remember if I ask you guys to start CPR on somebody, what the cadence is? What's the rate, right?
Yeah.
Simple things like that. Just talking about it. Just bring it up as a topic. Or even here's another one for 5 minutes. Hey, guys, and this is what I use in my training, Grant. Like this will really reveal a lot. I really I like using this as a question, and this gets your team ready. Hey guys, today I guarantee you we're gonna have a sedation emergency. Guarantee you. At 1 o'clock today, I know we're in our 9 o'clock huddle right now. We're talking about the cases, but I guarantee you, I just want to talk about something very important. I want to hear your input. This is how you. So let me take a step back. You want to set the environment so that they can speak up, right? So this is what you say. Hey guys, we just talked about our cases. I want to talk about something very important. We are, and I want to hear your input. Okay, I'd love to hear input and your feedback. I'm going to tell you right now, today, around 1 to 2 o'clock, one of our cases is going to have an emergency. I guarantee it. I don't know what it's going to be. I don't know where it's going to be, but it's going to happen in our office. It could be a patient, it could be a staff member, it could be me, but I guarantee it's going to happen. Do what do you think if that was going to guarantee to be happen today? What do you think we need to get ready for that emergency? And how do you think you can help? And just stop. Just stop there and stop talking. I know oral surgeons like to give their mind, and dentists do love to speak their mind and tell you what should be done, but just
Yeah.
stop. All right. And what you're going to do is you create that space for your staff to give you feedback. You're now giving them the platform to speak up, and they're gonna like, what? Wait, what? There's an emergency? Yes, I want to hear what you think you're gonna do, and uh, what we're gonna do should that emergency happen. And what you're gonna do is you're gonna learn that people have, and this is what we found out, that people have different opinions about something that you had no idea about. Like, oh, you don't know where the O2 tank is? Oh, you don't know how to put a mask on a patient and mass ventilate them? Oh, you want me to tell you everything that's going to happen? Like they're going to reveal to you where your weaknesses are.
Yeah.
So that's part of culture. You're starting to create that culture of I want to hear what you have to say. And if it you may also turn out like, oh, but how do we know there's an emergency? Like I will tell you the number one thing, not number one, maybe the top three that we've learned is there's a lot of offices that don't know how to communicate. There's an emergency going on to the rest of the office, right? So here you are, you're with your two assistants in your operatory. You're doing a sedation case. Say it's an extraction for some abscess tooth, and it's some patient that's 70 something years old, and now they're not behaving right. Just say their numbers aren't. They're just not looking great. They're not breathing well. How does your team communicate that something not is not going well to the rest of the office? How do you onboard the rest of your office for that emergency or a potential emergency that you don't want to get worse? Like, how do you communicate that? Are you just yell out on the hallway, "Hey, get over here!" And like, yeah, like what do you do, Grant? Like, what do you do if there's an emergency in your office? Like, I'm curious.
Yeah, I mean, because I've been in an emergency where that didn't happen years ago, and I didn't even realize it, but I had said, okay, let's activate EMS, and nobody knew or was too afraid to go up, I guess, and tell the front desk to call. And so, like, literally after 5, 7 minutes, I'm like, so are they coming? What was it? And they all look at each other like, oh, well, we never told them. I'm like, what? So I've realized you have to, say to your assistant, Ginny, I need you to go up front and talk to Deborah, our manager, and tell her right now to call EMS. Like you have to name names, you have to be specific. If you just say someone call, I feel like it never gets done. Like it's so stupid.
You know one thing about most emergencies, or almost every emergency, um, there's always somebody there. Somebody get the equipment. Somebody get call
Yes.
911. Somebody start CPR. Somebody do mass ventilation. The word somebody or somebody is always there. And the problem with that is it's a communication issue, right? Because if you don't call out names or assign roles at the start, it delays care. Perfect example, right? So these little exercises surprisingly makes big adjustments, and you won't know when it's going to help you because it's a halo event. It's a halo event.
Yeah.
But what surprisingly, when you start having those little um, huddles and you start asking your team, "Hey, listen, I want to talk about something very important," and you do this regularly, you actually will see your team become better teammates to you. They start communicating better with you. They start sharing things more with you that you never really thought about because you're in your little oral surgeon world, right? And viewpoint. But they start seeing things that your practice has never recognized before. Okay. And so the whole calling 911, for example, when we do our simulation training and this topic comes up, we've had offices say, you know what, let's create a code phrase or code word that activates an office emergency, and activates an office emergency. Not necessarily call 911 yet. It just means get more people into your office, into that operatory. And then now you got more people there. Now I can start assigning roles more effectively and more efficiently. So the point is, as you said, these little huddles, these little 5-minute things, 10-minute things can really improve the chance you're going to save someone's life. It really will.
100%. I love this. This is some this is some good stuff. Another question I had is just, you bring up how we got to check our equipment, have all the right equipment. Um, for an oral surgeon, because I think, like you said, oftentimes someone could go in and look and stuff's expired, stuff has never been opened, and there's just like this thought that you have the right stuff. We also have all of our anesthesia equipment. A lot of us now even have like video laryngoscopes that sometimes we've never really even used on a patient. All sorts of things that require batteries, that require things to be like checked up on. What do you recommend as far as a good system to make sure your equipment is all like in working order?
So what I hear you asking is, how do you make sure that when emergency happens, my stuff is actually working?
Yeah.
All right. Great question, because obviously it's like anything else. You want to make sure that your equipment works. The problem with the situation is you're like rarely going to touch it. Like you might maybe look at it once every 3 to 5 years, right? And unfortunately, maybe during an emergency. So we got to break that habit. We got to make it more of at least a monthly, better weekly, or even daily activity. And so one way to do this is in your huddle, like this 1 week huddle that you want to do on this medical emergency or sedation emergency training. Get your team, make the huddle around your equipment. So guys, hey, if we have an emergency, I need a adult mask. Do you know where that is? And actually stand back and see if they know where it is. Okay. Do you know how to hold the mask on the patient and see how they perform, see what their behaviors are like. And that will reveal, again, where your deficits are. In terms of airway equipment, hey guys, I need a laryngoscope blade. Do you guys know where to get it? Okay. Do you know how to turn it on? Do you know how to make the blade light come on? All right, good. And laryngoscope, not laryngoscope, the video scope. Do you know how to, can you open that for me? Is the battery charged? All right. So literally ask them, and not in a mean way, right? You again, you want to create some psychological safety. They're not going to help you if you're going to be scolding them. It's about inquiry. You're curious, right? If you're really genuinely curious, people will try to help, right? And you'll be vulnerable. You have to be vulnerable. Like, listen, guys, I really need your help. I want to know where we are as a team, right? Don't make it about an individual person. And I really want to make sure we're ready for emergency, right? Patient care is important to us. You know that's important to me. I want to give the best, but I need your help. So I want you to go through this little exercise. I kind of got this idea. I listened to Grant Stuckey's podcast recording with Richard Marn. It was so awesome. Not only are they fantastic, but they're handsome too. Hey, you got to listen to yourself. But this is what I took from it, okay? I just want to know, I'm curious. I want to know where everybody's understanding for a airway emergency is. And part of that is my equipment. So here's equipment, okay? So do you guys know how to use it? Do you know what this is called? What is this called? It's a laryngoscope blade. Okay, do you know how to turn it on? All right. Now in emergency, do you know how to get it to me? Like how to hand it to me, or how to get the stylet in the breathing tube? I find you literally have to go step by step with some of your staff because they don't know. You know a lot. You're an oral surgeon. You've been through it. But there's a gap between your knowledge and theirs. And there's a big assumption that we make, not just me as an anesthesiologist, you as an oral surgeon, but even them as assistants. They assume you're going to know exactly what to do and how to do it, and they will just stand by and wait for orders when you actually want some help. And so that's what I would do. I would literally have a huddle going over your airway equipment. And the next step is this, Grant. Assign somebody to go through it, maybe two people, so that there's overlap in case one of us is an emergency. Hey guys, I know we went through this little huddle yesterday, but I was wondering if two of you, if two people can volunteer to just talk about um, can you just two of you? I need somebody to check our equipment every week. You guys, I'm going to let you figure it out, but I need two of you, maybe three. I just need you guys to make sure this role is taken care of so that every week the equipment is checked, the laryngoscope light turns on, the battery's charged, the stylet is ready to go, the medication's not expired. In other words, you have and assign a liaison, a person that would be your emergency a spokesperson and or spokes team, and they will. That's your responsibility. So now you take off some of that burden off you, Grant, because you don't have to be worrying about this. Let them, and also you may not want to assign somebody. Maybe you get people to volunteer, because when people volunteer, they're more likely to lean into it, right? And so, because if you assign somebody, it's more like compliance versus if someone volunteers for it, it's more proactive, right? So now you assign one or two people and you say, listen, I need your help. I need someone to make sure the equipment's up to date. I need you to check the CPR, the defibrillator, make sure it's charged. And by the way, we're going to create an Excel sheet. So every week, or even a printout, I'll put it on the back of someone's door. Hey, this was checked this week. And literally you have your office manager put a printout for every week, and then someone has to initial when all the equipment was checked. And you can, if you want to get real minutia, you can actually break down all the equipment, column by column, airway stuff, oxygen regulator, oxygen tank, also the defibrillator, and you literally have someone checking it. So there's a cadence there. It's top of mind, and that's a great way to get your team involved in making sure your equipment, not just your airway equipment, but all your equipment is ready, and your medications, and your supplies, and your visual aids.
I
Is that
love that.
helpful? Is that helpful?
Yes, that really is. Yeah, I think it's important to have someone checking to go through it. Sometimes I've even in the past like incentivized them and said, I'll pay you an extra $100 to go through the kit this each week and whatever it takes, right?
Whatever works.
Yeah. Here's another idea which I wanted to run by you. And this one is a little more maybe sensitive, but here's an example. The concept is like trying to do as much um, usage of potential things that could be used in an emergency on like real life patients that you're seeing, right? But who needs stuff? For example, I noticed when I was because we did a podcast series on emergencies and we went through tons of problems that went wrong in oral surgery offices, and we were going through and wading through all this information trying to figure out what went wrong and talking about it. And one of the top things I noticed that had been a failure was inability to use a reversal drug when one could have been used. That seems to be a common thing. And so, I use Versed, for example. And so the thought occurred to me, what if I was to use some flumazenil and reverse a patient who maybe was taking a little bit longer time to wake up, right? And I know this maybe could be a dicier situation, but in our case, If a patient's not waking up and that we've given them a little more Versa than usual, I'll give them a little bump of flumazenil. And with some regularity in the office, we're using it. That way, all of our staff knows what flumazenil is. We have it, we're checking it, that type of a thing. Um, or what if you were saying, hey, this patient's totally fine, but let's get out the mask in the ambu bag, see how it fits their face, see how, I don't know how you use it. How do you hook it up to the oxygen while a patient's in the chair? Is that unethical, or what are your thoughts on doing things like that?
What's your question, Grant? Just to make sure we walk through a scenario. It sounds like an overdose a little bit on a benzodiazepine, and we're talking about reversal, but then we're also asking about the airway masking skills. So I'm sorry, just want to make sure I understand what your question might be.
Well, the question just is, like, how much can you integrate into what you're doing for each patient every day? Are there things you can be doing for your staff to make them familiar with things during the day? Because I feel like a lot of us, that's where the focus is on treating the patients. And it's hard sometimes to say, okay, well, let's stay an extra hour and go over emergencies or an extra thing. What could we be doing on the actual, patients? Can we stop while the patient's recovering and let's pull out an ambu bag and a mask and all that stuff?
Great question, Grant. So again, we're talking about how can we stress test your
Mhm.
team to make sure they're aligned, right? Like we talked
Yeah,
about at the beginning, right? You're basically like, how do I like get get their alignment in line with me together? And we're kind of do a little stress test. Here's a question I think you're asking. Okay, so we have a live patient and we're giving them some medications. How can we do things to kind of safely practice on the patient?
right.
Is that yeah? All right. So I'll give you examples of what I've done. All right. So I take care of small kids. Like my typical kid I take care of when I get called to an oral surgeon office or a pediatric dental office is 3 to 8 years old. That's my sweet spot. Obviously, I take care of much older kids and adults, but I take care of a lot of 3 to 8 year olds. So what I'll do um, sometimes I'll say, listen, hey, after I get the IV in this kid, and we're gonna do a nasal intubation, right? Maybe it's a long pediatric dental case. They love their water, and so we'll do a nasal intubation. Okay, fine. Okay, so we got the IV in. Okay, so I give them medicine, they fall asleep, and we put the mask on the face, and we do a little positive pressure ventilation, make sure I can breathe for them. What I'll do at that moment is I'll say, listen, um, I'll say to the dental assistant or the pediatric dentist or even the oral surgeon, listen, I want you to mask ventilate the patient. And I'll tell them this in advance. I'm not going to surprise them, but I'll say, listen, I'm going to have you mask ventilate during this case, literally for like 10 seconds. I just want you to practice how to hold a mask on a patient. They're unconscious. The stats are totally stable. I know how to
Mhm.
rescue them. I definitely know how to mask ventilate. But I want you to practice. I want you, all right? And they literally were like, oh, okay. They put the mask on the face. All right, now take the mask off. All right, now put the mask on. Now it's great where I put the mask on the patient and they mask ventilate. But what if the mask comes off and I'm not there? Do you know they know how to put the mask back on the patient? Because masking is a very important skill. If like I'll give you an example. If a patient has any airway issue, I can save 99 point, well, maybe 98% of all situations because I know how to mask effectively. Right? So if you know how to mask well, it can help you buy time and get you out of problems more so than a laryngoscope intubation or video scope intubation or LMA placement. Like if you know how to mask ventilate, you can save yourself and save that patient um, more times than not. Right? But anyway, I'm digressing.
Yeah.
So what I do is essentially allow the dental team and the oral surgery team to do the things that I would sometimes do, like mask ventilation. I would literally get them to put gloves on, put the mask on the 5-year-old kid. Now I want you to bag the patient with my system that I have. So they bag
Hmm.
the patient and I literally let them practice. And they're like, wow, that was really awesome. And the patient's safe, by the way. I'm making sure they're doing it well. And I give them
Right.
my little tricks on how to mask ventilate somebody. But now you literally gave them a extra skill that they could practice. Now, say, I know you don't grant, most oral surgeons like yourself do not do deep sedations like I do, right? So the opportunity to do that, unless there's an anesthesiologist there, is not very high. But you can still, give a little Versed, maybe some people give ketamine or fentanyl, and then a little propofol. After you get that propofol, some patients kind of like do some breath holding, or they get very unconscious and a little sleepy. Put the mask on there. Practice getting the mask on, and just practice putting the mask on a patient that's basically sedated. They won't know, right? And you're actually letting your team practice. You don't have to mask ventilate. I mean, you don't have to ventilate per se. It's just practicing putting a mask on the face well. What happens is a lot of people, when they put the mask on, they go just put it around the face and put a notable amount of pressure on the face that's too hard, and you're actually obstructing the airway. They don't know how to put the mask on. A little chin lift, jaw thrust, maybe rotate the head actually helps. And they have to just practice doing that. So
Yeah.
that's one skill. Second skill, some oral surgeons, when I'm doing their cases, sometimes I need to place a nasal trumpet or a nasopharyngeal airway into the nose. So I do that all the time. But what if I'm not there and you need to do it emergently? So what I do now when I'm doing sedation case, again, total elective, everything's safe and stable, I will let the oral surgeon place the nasal trumpet in. I'll let them quite honestly practice. I'm there guiding them as if they're residents, but they're literally practicing a nasal airway placement with obviously guidance as a third party. And the oral surgeon I just did this with 3 weeks ago, loved it. Hey, can I do this? Yeah, so yeah, sure. And they did it quickly. It was done in like 7 seconds. But
Nice.
again, it's the little things, these little things that add up to and make it a habit, right? It's a regular thing. These little things that allow your team to feel more confident, even if the anesthesiologist is not there.
Yeah, that's fantastic. I think always keeping this in mind and figuring out ways to integrate this into your work, making it like you're saying with frequency and communicating this well, having individuals assigned to certain tasks. It's just so critical. Um, I mean, I know we're running low on time, but as far as truly stress testing, how do you create this environment so that in an actual emergency, when, there is very high stress going on, that people can
Mm,
still function? Let's say you have an assistant who's only 2 or 3 months, she's never actually been in an emergency before.
yeah.
Like, how do you help someone like that to feel comfortable in an actual emergency?
Was not overnight, as you know, Grant. It takes time, and it's getting there. It's slowly getting them involved in the case. So you have a standard 18-year-old that you're doing a wisdom tooth extraction on, right? Have them be there and actually um, talk to them. Hey, listen, you have so that I think a lot of times people get so focused on the skill, right? Hey, you
Yeah.
got to know how to suction. Have to know how to put a mask on a patient. You have to help me learn how help me with an IV placement, or get me the tools.
Hmm.
When what you need to start with, I believe, Grant, is you have to first create a safe environment, right? You have to address that culture aspect. So because if you create a safe environment, they're going to want to help you. And of course, you're going to get certain employees or staff that don't care, right? And those are the people you don't want in your team. Or you reassign them, or maybe they're just not well aligned with your objectives. But if you really care about the patients and you got the right people and you really like someone to onboard them, you literally train, just talk to them. Hey, listen, I think you can help me out. If we have an emergency today, how do you think you can help me?
Hmm.
Ask them. Oh, well, I can do this. Oh, and they will actually reveal to you what they can do. Who knows? You never don't know. They may have some skills you never even knew they had. Oh, I used to be a phlebotomist. What? Maybe you can help me place an IV in an emergency. Yeah, I can do that. work with this oral surgeon. They have someone that was a phlebotomist in another country.
Mm.
And that could actually be helpful, right? You don't know. So
Yeah.
literally asking your team how they can help. That's the first step is just creating an environment where they can speak up and reveal their strengths and their weaknesses. And then start small. Hey, listen, I think that's great what you can do, but here's something I'm thinking that could be helpful. All right. So if we have an emergency, one of the most important things I need access to is medications. And it's not in this room, it's in the other room. Do you know how to get it? Like, in other words, you're not going to give your newbie of 2 to 3 months some high advanced skill training at the moment. You're not going to tell them, okay, if we're in an emergency, you're going to have to hold the mask in a certain way. Like, that's not their skill set yet.
Yeah.
Get them started with something smaller. Like, do you know how to call 911? Do you even know the address to our location if you call 911? Oh,
Hmm.
I don't know the address. No, I've only been here 2 months. I know where to go. No, I can figure it out. No, no, no. You don't want to figure it out when the patient's having an emergency. You know what? Let's do this. Where's a place that we can put the address for our location that you can see from your phone? Well, let's put the address of your office here in big letters so we can see it no matter where we're standing in this room. You'll be surprised when panic hits, people forget simple things.
Yeah.
So a mentor that used to coach me, he said, and I always use this in my presentations. When emotions go up, intelligence goes down.
Yeah.
When emotions go up, right? You're panicking because your patient's life is on your hands. You're taking your intelligence goes down. I mean, listen, I get in squabbles with my wife. I don't make the best decisions because I'm so flooded and heated up. Like,
Hmm.
that's a natural human reaction. So we have to we have to keep that in mind, but also practice. And so I would first start with a new employee, 2, 3 months, start small, ask them about their strengths and weaknesses in a very non-threatening way, and tell them about how they could help, and then walk them through. Okay, now we want to address the first pillar, right? The infrastructure, right? Do you know how to call 911? Do you know where the medications are? And advance them to the next part, right? Do you remember the CPR that we just did last month? I'd love to hear, I kind of forgot, I kind of remember most of it, but I love your feedback. Do you remember what is it? I just want to make sure everybody's on the same page. Do you remember what the CPR cadence is? Chest compressions, 2 breaths, right? Do we remember that? And literally 1 or 2 people will speak up, and the other people will be like in the background, like, oh yeah, that's what it was. And
Yeah.
it's fascinating, right? Because people do forget. It's a natural thing. We
Yeah.
just Our retention is not like a computer. We're not AI. We're human. So having that practice starts with you creating that safe environment, letting people speak up, and then you have a system where, okay, let me walk through those 4 pillars. Does that
Yeah.
help? I'm wondering if does that make sense?
Yeah, that helps a lot. Um, I think you're weaving in the aspect of culture into the competency, maybe helping someone develop these skills has to go hand in hand with creating the safe culture that you're talking about. So that would be 2 and 3 on your pillar thing. But
Yeah.
no, yeah, that's fantastic.
No, I
Um,
mean, you have a great word there, weaving. Listen, this is like residency, right? When we did residency, we were not told to, okay, we're going to do the most complex things to you on your first week of residency. They start you small. Hey, first thing you're going to do, you're going to write orders.
that's right.
You're going to write orders. Like, oh shit, what am I writing orders for? And then you're looking up the drug as you write. Like, what does this drug do anyway? I kind of remember it from dental school or oh yeah, and then now, right, you're starting small. And now you start doing it well, then your attending starts trusting you and they start giving you more. Okay, now we're gonna start practicing suturing. Okay, all right. And it starts small. And you know that attending in residency, like I remember a few I had at NYU, they're buttheads. All right, they were buttheads. And I remember what this one cardiac anesthesiologist, he was just nasty. Just nasty. And did I speak up if there's a problem? No. I tried to figure it out on my own because I did not want to get in trouble. And I hate to say that actually I had a bad situation because I did not speak up soon, right? And what happened was I called my attending too late, and the patient didn't have a bad outcome, but had a near bad outcome, and it was a big deal. But the fact is that the cardiac anesthesiologist didn't make me feel safe to speak up, and it hurt the patient. And so we have to learn from our own mistakes, but also the mistakes of others, and recognize that if you create a safe, it starts with psychological safety. I not start there, but that's a key component. That if you have that, your team is more likely going to help you. They're more likely to speak up, and they can be an asset to you versus a burden.
Mm-hmm.
And it's simple principles, right? Simple things, and that's. But and listen, we know what is good learning and what's not, and again, part of that is creating that safe space to work together and speak up. So I'm hoping this makes sense.
Yeah, no, I think it's a great for all of our listeners to just have these four simple principles, go through them, think about each aspect, infrastructure, competency, culture, habit, and maybe even list like what am I doing in each one of these categories to keep my team sharpened and their skills going well. Is there things I need to change with the culture? Have I been too hard on new people? Just as a side note, like I think this is a very hard one for us because for most surgeons, if you go through residency, there's usually a very, very defined hierarchy in residency, right? And usually it's the first year can only talk to the second year, and the second year can only talk, like an intern could never talk to an
Yep.
attending. The attending only wants to hear from the chief
Yep.
resident, right? He doesn't want to
Yep.
hear the intern saying stupid crap. And so it's like you need to be quiet. And so sometimes we treat our assistants like that, and like only my
Yep.
lead assistant can talk to me, and she needs to tell the other people this because I don't want to be bothered by all the, insignificant things that like a brand new person is going to say. I think that could get you in trouble when you're in an emergency because they haven't created that culture.
Well, let me ask you this: do you think an oral surgery office is like a residency?
I mean, I don't think so. I think I've tried to stop that whole concept, but certainly there's duties, and I think the more experienced person has more teaching opportunities. But I try to, like you're saying, as soon as someone's new, we get them in with me assisting. Um, I think I've seen other teams, like in other surgeons, who it's very hard to have a new assistant assisting you. It's a very technical thing.
Yes.
And so a lot of surgeons will say, "Oh no, you go back and sit, and do dishes and sterilization for months on end, and then slowly you work up to being able to assist." We don't do that. We start getting them doing all the tasks, but having somebody with them, and we pick the patients. Okay, this is the easy one, and they're sedated. Let's have you know this new person assist, and someone's gonna be watching, and we're gonna go really slow, and we're gonna create a great environment for you. Whereas I don't think most surgeons have that type of a patient and a mentality to do that. It's like, if you don't know what you're doing, then get out of my OR. And sometimes you even throw a hemostat at them or something on the way out. That's how it is. And it can be very damaging for your culture.
Well, I think that still exists and that will still continue for a lot of people. The question is, if you're an oral surgeon, do you want that? And you have to cultivate that. You're the leader of your practice and you can control your narrative. Like you can control the culture. You have a big impact on the culture. The culture is people. And if you have a bunch of a-holes, like, I'll give you an example. In cardiac anesthesiology, in cardiac surgery, there's a lot of not so nice people there, but it becomes from the top. And next thing you know, the perfusionist is like that, the circulators is like that, the anesthesiology, the cardiac anesthesiologist. No, they're all kind of buttheads.
Yep,
They don't have to be that way, but the people are creating that culture, and it kind of starts from the top.
for
Uh,
sure.
you know, I have a luxury of vetting out who I work with. Like I get to choose, like I don't work with buttheads. I work with some fantastic, very highly skilled people who are not rookies. That's who I get to choose who I work with.
Mm.
And you get to choose, if you're an oral surgeon, you get to choose who you work with most of the time. And you get to cultivate that. And if you are the kind of person that recognize, times out of 10, most oral surgeons are buttheads to their people. I'm not going to be that way. I'm going to create a different culture. You're going to attract better people. You're going to make more money than them. You're going to become a stronger practice. You get better reviews. And so be it. Let other oral surgeons behave that way. Let other dentists behave that way. You don't have to behave that way. All right.
Yeah.
You can affect your alignment. I'm a little preachy here, but it's so disappointing that people think they have to treat people a bad way to get respect.
Hmm.
All right. Mm. The uh the fact is, I don't think an oral surgery should be like a residency. It should be like a high performance team. If you look at the best high performance teams, Navy SEALs, if you look at how they operate, like I've been reading a bunch of books on the military lately, on safety. They don't talk down. Like I know in the whole the initial onboarding, it's like, that's they kind of push their mental fatigue. But when they're on the team, it's a camaraderie. There's certainly a hierarchy in terms of leadership, but there's camaraderie
Yeah.
with their team. You look at aviation, right, where the two pilots have to talk with the control tower and their flight attendants. They're not talking down to people. That's part of the culture. They know how to communicate as a team. Same thing at the best hospitals. I know there's this stereotype of how surgeons talk, but the hospitals I've been working at in the last few years, when I was at Mount Sinai, for example, and now I'm working with a Harvard hospital anesthesiologist, there's a lot of respect that they have for the rest of the team. I'll give you an example.
Yeah.
When you were a resident, your attending may have been talking down to you. I mean, you're right when you're talking down, but did they talk down to the nurse or the charge nurse or the anesthesiologist? Were they really that mean, or they kind of were more like a collegial with them? Like the oral surgeon, even your attending knew they do not mess with certain people because they're not going to get good performance. They're not going to get the tools on time. They're not going
Yeah.
to get the best staffing. They knew how to talk to the head nurse. They knew how to talk to the anesthesiologist, or else they're going to, it wouldn't be a very fun or safe environment to work in. Yeah, they'll maybe talk down to the residents because there was, maybe that's part of the culture they grew up with. But they in the environment in OR, you're going to be nice to your OR nurse, you're going to be nice to your circulator, you're going to be nice to your anesthesiologist, and it goes
Hmm.
all the way around. And I will tell you, as an oral surgeon, you are one of the main leaders, and you can create that culture. So no, it doesn't need to be like a residency. That you can, it's up to you, but you does not need to be like that. But
Yeah.
anyway, thanks for sharing, Grant. I know sometimes talk about residency brings up old wounds.
Yeah. And I mean, it's just unfortunate because I see colleagues perpetuate that. And the bottom line is like it hurts yourself. It hurts your practice. It hurts your ability to excel in an emergency if you
Yeah.
are, having a negative culture. So if anything, this is like helpful to you to have a good culture where everyone can feel like they can express their opinions. So anyhow, just belaboring the point there, but I appreciate you talking about these four pillars. I think this is a good way to start. And I like how you were kind of bringing it back to more of the principles as opposed to, here's all the specific techniques you got to learn,
Oh,
you know. That's a
yeah.
good way to overwhelm a new person is just like
Yeah.
make their head spin with 1,000 little technical things they got to do.
No. Yeah. And I hate to say a lot of webinars are like that. All right, we're going to talk about the 13 medical emergencies to worry about in your office. Like, oh my God. Yeah, you have to do it for CE, but in terms of retention, it's very low. Um, if you like, Grant, I can provide a resource for your listeners. It's free, it's online. It
Okay.
actually goes, it's a online assessment that looks at the four pillars. It asks about 5 to 6 questions, and it's a personal assessment you can take to
Nice.
assess your readiness, your own readiness
Oh,
for
wow.
a sedation emergency. I can put it in the show notes if you like and give it to you later on.
Yeah.
Or it's called, the web address is emergency.scoreapp.com. It's a resource I created. It's based on the 4 pillars. It goes through the questions. It helps assess if your own readiness in those 4 pillars. May show your weaknesses and your strengths. And also, once you complete it, it sends you a PDF. It looks very professional. I'm very impressed with the people that helped me put this together. A PDF that gives you ways to improve each of those 4 pillars. So it gives you
Okay.
some of those suggestions, some of what I shared already in this podcast recording, but it's available, and it's free, and and it's great for an oral surgeon who wants to, let me see how prepared I am in those 4 pillars. The next step too is you can actually potentially ask your team to take it. It takes 8 minutes to do. Ask your team to take it, and then and then you ask for their results if they're willing to share it, or I can share their results with you if we have this conversation
Yeah.
privately with someone that wants to do this. But what I recommend you do is, like, you do it yourself. I'm an oral surgeon. I do the test. Like, oh, I did okay. All right, I got this score, and it grades it. It gives me a score. I'm like, oh, I'm not bad, and gives me ideas on how to get better. But then you might consider having your team take the assessment, and then you get their viewpoint of
Mm.
how ready they think they are, or even the team is, for emergency. And then what you do is you take those assessments. You're like, oh, wow, I thought I was really good in here, but half my team is really weak on the competency. Like, now you got like an objective assessment for this, for their readiness, not just of you, but your whole team. So anyway, this is a new online assessment. It's free. It takes 8 minutes. It's easy. It's anonymous. I don't share this information with anybody. It's all private. But the point is, it's the only tool I know of online that allows you to assess your readiness for a medical emergency or sedation emergency.
Love that. It's Blue Pacific Medical Simulation. Is that
Yeah, that's our company name. It's just we have to create it to deliver on the mission of creating safer sedation emergency systems. I had to create a company, and so we named it after Blue Pacific. I grew up in Hawaii. I think of something big. All right, it's
yeah.
in the Pacific. It's blue.
Nice.
That's how it came up. I will say that the online assessment I just told you about, it was initially designed for pediatric dentists and medical emergencies, but the principles are the same. It still applies to sedation emergencies, even in adults. It was just originally designed for that. And so, just if you could ignore the little nuances of how certain questions are phrased, you'll still get feedback that's very valuable, to really anybody that's worried about sedation emergencies.
Awesome. Okay, well, I'll put if you're okay with it, I'll put your contact in the show notes. I'll put the link to emergency.scoreapp.com on there, and just some of the other things we've talked to. So that'll be a good resource. I
Awesome.
really I really appreciate you taking the time to talk about these 4 pillars and share some of your knowledge and experience. It's really nice of you to do that.
No, my pleasure, Grant. I really want to try to help out the dental industry. Honestly, I think this is an area that needs attention, and I'm trying as I can to try to bring attention to it. That's all. So thanks for having me. Thank you
Awesome.
very
Thank
much,
you so
Grant.
much. Love to do another episode sometime if you're open to it.
Yeah,
That'd
there's a
be
lot of
great.
things we could talk to about.
The way our schedules work, it'll probably be a year from now,
It'll be a decade from now. If listeners don't know this, Grant and I have been going back and forth for like what, 2, 3 months.
at least
I was sick, then you had a scheduling conflict, and I had a scheduling conflict. I mean, it's like, oh my God, it was
out
back
of
and forth.
town. Yeah. Oh man.
So
All
very glad
right.
that we got connected. But listen, anytime you want to reconnect again, we can talk about a whole bunch of other stuff, sedation related items. It doesn't have to be about emergencies. We talk about mobile sedation services. We can talk about talking to parents, challenges
Yeah.
with that as well, when they're faced with sedation or um, um, sedation for their kid and dealing with parents. That's another thing, how do you deal with parents in emergencies?
Yeah,
You
that'd
know?
be great.
So anyway, happy to help out if I can, Grant. And I think you're doing a great job, by the way. Your reach is awesome. You've been consistent. You have habit about your podcast recording. It's quite impressive for a young man like you. Very impressed.
Appreciate it. All right, Richard. Well, have a good rest of the day, and I'll keep in touch. And let's keep changing the world with good podcasts.
Yeah, no kidding. I totally agree. Thank you very much for having me.
We'll see ya. Okay, bye. Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstuckey@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.